Thank you very much, everyone, for coming. Thanks to Dave for kind of planting the seed for this grand rounds in my head, and kind of helped shape a lot of what you guys are going to see over the next hour. So thank you to him. As he said, I got a particular interest in resuscitation, and not just the technical aspects of resuscitation, but a lot of the CRM factors and cognitive factors that go into it. Really the cognitive hurdles between ourselves and between the rest of the team. I have no conflicts of interest for this talk, aside from the fact that I am interested in the conflict that we all go through during a bad resuscitation. And I hope to translate a lot of what I learned from these amazing guys in Sydney, watching them on a day-to-day basis fly us around, winch us out of their helicopter and do it safely, and translate what they taught me into what I do in the emergency department. Now, being this is QI rounds, I am going to introduce a couple new initiatives that are rolling out. It's absolutely nothing mandatory, obviously, but I'm hoping to at least spark some of your interest in using the tools that I'm going to present to you, and really getting as much feedback as possible. I want this rounds to be informal, so please don't hesitate to shout out questions and comments while I'm speaking. So, I mean, I'm in a room here, largely of emerge docs, I think, nurses. Everyone here knows how to resuscitate a patient. We've been mandated to take courses like these that are all over the world, so we essentially know what we're doing. But then you're taken out of this course environment, you get a bad call overhead, and then all of a sudden you're asked to go into a room and you're just confounded by the blood and the mayhem and the people running all over the place, and you're immediately expected, as the resuscitation, to gain control of the situation. And how do you get control of the situation? Get control of yourself, which is one of the most difficult aspects. Get control of your team, all the while remaining patient-focused and thinking about your next step. I think those are really interesting questions. So I'm going to base what I talk about today around a real case from a few months ago. And I just want you to imagine and kind of delve into this case with me. You're working at UH, it's an evening shift, you're about 7 hours in, you've been awake for probably 18 hours now, you're approaching midnight. Your eyes are just burning from the bright lights of the emerge. There's a screaming child in the other pod, and your resident's telling you about D-dimers on patients with toe pain. You're going crazy, just trying to pare down what you want to do. Your resident's presenting this case, you're going to interrupt it again and again to review ECGs, to review lab work, and all the while you're looking at this board, wondering how did this blow up like this when I've been working my butt off for the last 6 hours. It's a really tough place to be. You know, a patient pops up on the board, direct to GI, C-task 2. You don't really worry about it, that happens all the time. You continue with seeing and assessing your own patients. Well, until it does become your problem, and you get a call for Dr. Resus immediately. So you walk over, you don't know anything about this patient whatsoever. You walk in, you see a young guy, probably in his late 30s, early 40s, just yellow as a school kid's highlighter, spewing blood out of his mouth, active hematemesis. He's sitting up, holding a K-basin, he's already got dry blood. All the while, this patient's just staring at you, just with that look that we've all seen before, just, "Doc, please don't let me die right now. I am not ready to die." He looks like absolute crap. You know, there's a certain chaos that's developing in the room, right? The nurses and the EDTs, everyone's running to get monitoring, to get IVs, to try to figure out what the plan is, and you can see the situation slowly growing out of control. The GI junior who was receiving this patient, standing in the corner, he's got his clipboard in hand, dressed like I am today, wondering, what the hell is this? I didn't expect this from Goddard. And this is unfortunately what showed up. So you have to gain control of the situation. You walk in, you're in a resuscitation room, and all of a sudden you're met with a room of people who you may have never worked with before. You got a nurse transfer who's brand new from the gen surge ward. She's on her first couple weeks in the emerge. She's really excited about being in the trauma room with you. You got the RT who just finished school, who's got a job in the emerge. He's really excited about airways, and he's trying to find that color capnograph for you before you get started. Right? And then you got the other nurse who's getting married in a few weeks, and just a few minutes ago, she was looking up wedding plans and wedding videos during her break. And now all of a sudden you have to walk in, get all of these people on the same page for the benefit of your patient. So again, for anyone who kind of came to my rounds in May, I presented this slide. There's really 4 main domains of resuscitation, outside of the technical aspects that you really got to gain control of before you absolutely lose everything, right? First thing, you got to get control of yourself. And how do you do this? I do things like breathing exercises, self-talk. Anderson's rolling his eyes already. Are you kidding me?
I didn't think you could see that.
Not enough video. But all this stuff helps, right? The situation is getting out of control. Your heart rate's going up. Your blood pressure's going up. How do I slow this down to slow down my thinking? Breathing exercises are one way. All right, I'm going to focus on my breathing and slow my breathing down so that I can focus on the next task. You're going to visualize your next steps, what you want done successfully in your head. You're going to turn to your cognitive aids, which I'll show you about later. In terms of controlling your environment, I mean, this was a big challenge when I was working pre-hospitally, but it absolutely applies in the emerge. You're in a busy resus bay all of a sudden where there's 3 beds and probably 10 staff and a few patients in there that you immediately have to gain control of your real estate in order to achieve what you want to achieve. Get extra hands if needed, ask people who are just standing around to exit the room, maybe move the stretchers out of the way so you have room for your tray tables and your ultrasound machine. You know, immediately the team of people in the resuscitation room are going to be looking for a leader, and it's important for you to walk in and be that leader. So assert yourself, and things as small as how you stand up straight, how you speak and project, how you make eye contact, all determine if the people you're trying to lead will actually follow you. It's really interesting psychology. So now, priority statements I'm really big on for anyone who's seen me. All right, so we got a patient with a massive upper GI bleed, guys. He is really sick. We need to get 2 IVs, we need to get labs, and we need to prepare for RT. Then I go and I direct my care. Nurse 1, you're going to work on 2 IVs and you're going to draw labs. Nurse 2, I want you to hook up the monitoring. Charge nurse, I want you to get these drugs. RT, I want you to start preparing for intubation. So you ask the nurse to get some vitals for you, and this is what pops up. This is your patient, and he's sick. And really, what are your next steps? There's a lot of things going on here right now. He needs his airway protected. He's actively vomiting blood, bright red blood. But you can't get a blood pressure. He's sitting up. He's talking to you, especially if you yell loud enough. So he's got to be perfusing something, but he's so peripherally shut down, you can't get a sat or a blood pressure on him. What are you going to do? There's all kinds of ways that this guy could die in the next 10 minutes on you, especially with the interventions that you may want to provide. Dorian, what's going on?
Well, I think there was a discussion about this case at some point in the past month or so. Obviously, airway is a big issue for this person, but your lack of blood pressure was a concern that you had. I don't really want to give away what your decision was, I think, at the end of the day. But.
All right, well, Chantel's keen. What do you think here?
Okay, so I think I have kind of 2 priorities. I want airways my first one, and second, we need blood, we need fluids, so I want to make sure we have, you already kind of have the monitors and everything set up, but I would try and get blood bank calls, get massive bleeding protocol started. And
so blood's not going to be here for 10 minutes maybe? Are you going to go on tube this guy? He's up, he's talking to you, he's holding his K base, he's vomiting. You can't feel any peripheral pulses, he's got central pulses. Don't know what a SAT is. Who would just, he needs intubation, no one's denying that. Who would just proceed with tubing him right now? Any takers? All right, we'll let Wood. Okay. Anderson,
Yeah,
all right.
I'd like to agree with Willette, but...
It's difficult, yeah, absolutely. Now,
I guess the difference is I would get 2 bed.
okay. Well, who's going to consider an arterial line before they go and proceed here? I mean, we see a couple hands, 3 hands. Okay. That's what I did, getting my airway equipment ready. So I was ready to pounce on it if we had to. But for me, in this situation, I want to collect as much information as I can. This patient has no SAT, no palpable blood pressure that it can record. I need to find some. I need information. What drugs it's going to affect what drugs I use, what doses I get. With ultrasound, you can get an art line start to finish in probably about 3 minutes from when you start the procedure to stitching it in. I think in this situation we had 3 minutes. I was prepared to move more quickly if we had to, but it's a good question. There's no right answer. I mean, is it overkill? It would be just as reasonable from talking to my colleagues about a case like this, it would be reasonable to just give them a bit of whatever medication you want and move on with your intubation and then deal with the consequences afterward. But there are many ways that you can kill this guy right away when you proceed with intubation, right? He's profoundly shocked. You have no idea what his blood pressure is. He's got a metabolic acidosis, or it looks like it. He's sitting there huffing away like he's just run a marathon. And he's got active bleeding, so he needs his airway control. So he has all kinds of ways that he's going to try to die on you. My view is you resuscitate before you intubate. Now, I'm going to use this form as a bit of a soapbox for talking about propofol, because it's a good drug in some situations, but I honestly believe the way in which we as emergency medicine have used propofol over the last number of years, we are executing sick, hemodynamically unstable patients, whether with sepsis or with trauma. There are so many better options than propofol out there. Again, it's not a bad drug, but you have to think about what doses you're using and do you really have any better options. And you're in an uncomfortable situation right now dealing with an upper GI bleed who's got no blood pressure. You give him the wrong dose of this drug and now, sure, you may revert to your familiar ACLS protocols pretty quickly when he codes, but I say avoid that situation from the get-go. So rocuronium and ketamine are my go-to drugs for basically all my hemodynamically unstable intubations. Propofol you can use, but it needs massive dose reductions in a patient like this, 90%. So if propofol is the only thing that you have at your disposal, just be wary of the dose that you're going to use. This is a chart from the study of patients who are hemodynamically unstable, and they calculated cerebral level of these drugs based on regular dosing. So propofol needs a 90% reduction in dose. So you're talking maybe 10 milligrams to someone like this. I already talked about rocuronium and all of its advantages with increased apnea time, and this is a difficult airway. I want to be ready for my next steps. If I fail right away, I want to make sure the patient's optimized for my second attempt. So this slide right here, and this goes to resuscitating before you intubate. Now, I think really the only important part's the bottom right of that slide. I've also been on my soapbox this past year about the use of phenylephrine and how it's pre-drawn and stored in our ICUs and in the emerge. And again, it's just, there are so many better options than phenylephrine. In every study that I've seen for phenylephrine, yes, you're going to get a good macroscopic number of your blood pressure, but inevitably it will decrease the amount of flow that you're going to produce, forward flow you're going to produce, your cardiac output. It's going to increase myocardial oxygen demand. There are better drugs. Start some peripheral norepi if you need to. This guy needs blood at the end of the day, but phenylephrine boluses are what this gentleman does not need. So unless you're a dermatologist, stick in a central line. So I did do a blood gas, and this is what ended up coming back. Here's his, I wanted some more information. I threw in an ultrasound-guided art line, and as expected, he's profoundly acidotic with a lactate of 15, bicarb of 5. And now I have a little bit more information for when I go to intubate him. How do I intubate the profound metabolic acidosis patient? Any of the fives? Chris, any big tips there?
I think one of the key main considerations is to match his ventilatory rate after you pass the tube.
Yeah, so after you pass the tube, absolutely.
Yep. Before that, on induction, you probably bolus bicarb.
Yeah, so bicarb is a good idea. I don't think there's any real evidence that it works because you need someone to increase the respiratory rate to blow off the CO2 that you're going to give them with bicarb. But yeah, it is an idea. Bagging them through the apneic period is a big one. If you keep this guy apneic, his CO2 will rise, he'll get more acidotic, and he will arrest on you. So bag him through the apneic period. Connect your waveform capnography as soon as you can, even during your BVM to preparing to intubate. Get a baseline of his end tidal, and then you have a goal to aim for to at least match, if not exceed, once he's on the ventilator afterwards. So again, you need a plan. There's a lot of things going on with this guy right now, and they're all running through your head, but you need to make sure everyone else on your team who's going to help make this happen for you is aware of your next steps and the potential pitfalls. The other big point with this is that this is a really difficult intubation, and this gentleman needs the most senior intubator or a very senior intubator doing the first attempt. Unfortunately, this isn't a case to let the off-service PGY1 intubate. If he's apnea too long, he will arrest. So there's a lot of things you want for setup for this guy. Mark, you want to just shoot out a few things?
So going through the piece, so the preparation first, we would want probably size 8 DC tube with stylet. Gonna have our oral airways at hand, nasal airways if need be.
Sure.
He's gonna have nasal prongs on.
Yep.
A mask if we can get him on. Get it on.
What position do you want him in?
With the bleed, right now I'm gonna keep him probably 30 degrees head up.
Okay.
I'm gonna have two suctions going.
Yep.
I'm gonna have two helpers on hand to manage those suctions if need be.
Yep.
I'm gonna have Untitled CO2 econometry available and ready to set up once intubated.
So you can see you're running through.
I'm also going to consider the use of a checklist.
Absolutely, yeah. Excellent point. Yes. Well, no, but you can. Anderson, stop rolling your eyes. But you can see. I mean, this isn't really that. It's a little bit stressful getting asked a question in front of grand rounds. But compare what you're doing now, running through your head, trying to think, what do I want to intubate this guy who's trying to die on me, in all these kind of different ways. You're thinking about it, pausing. You definitely didn't just quickly come up with a few things that I would have. And now take yourself and put you in the resus room with this patient. How do you think your mind is going to perform? What are you going to leave out? What are you going to omit that's potentially catastrophic for this patient? So is there a better way to do what we're doing? And essentially this is the main purpose of the grand rounds here, is do real airway experts use checklists? And I think you all know where I stand on this. I'm going to get Dave to come up at this point and tell you about why he thinks checklists are useless, but I'll provide a quick rebuttal afterwards.
Okay, should airway experts use checklists? And I am the counter argument, well, like it or not. So a couple of misconceptions first about the checklist. Checklists do not make you a good intubator. Checklists do not make a difficult airway better. And checklists do not make the team that you're working with have any skills or have the skills sufficient to complete the task that you're doing. If you run a checklist, this guy's not going to pop out right after you're done and intubate. After you run your checklist, these guys are going to pop out and help you. And nor are these guys. So you have no help after the checklist is done. It's simply gathering your equipment. It's really a technical tool, and a lot of times in medicine it's being applied to an adaptive or a sociocultural problem, which I think is a bit of a loss of translation from when we've gone from aviation to medicine. Right? You can't put a square peg in a round hole. A managerial tool cannot replace the proper training, and that is the real crux of why, you know, it's really the training that's the issue and not the checklist. So therefore, we may not even need any checklists at all. The research, there is some research here. When you take a look at the studies that were done for checklists, and I'll get to them, I'll show you a couple. Most of the studies have implemented this 9-month process of education, of senior leadership, of training sessions, of buy-in, this cultural change to the hospital. And then they report the study as the checklist has improved mortality and morbidity, when really the checklist was one tiny portion of most of the studies. So there really aren't any studies that demonstrate that a checklist does anything really. I mean, in the aviation world, some of the simple checklists have some data behind it. So many successful studies, many failures. It's like steroids and spinal cord injury or sepsis, or activated protein C is in and out and in and out. It kind of illustrates the underlying difficulty in, you know, whether these checklists work or not. And there's been some recent studies suggesting failures, or at least non-improvement. So this is one study about I think it was 2006, New England Journal of Medicine, one of the earliest studies that came out. And this study actually was the 9-month implementation of this cultural change. But the media and a lot of the people in medicine have viewed this as the checklist has made the difference, when the checklist was the tiniest portion of this study when you really look at it. It's the Michigan Keystone study. So it was quite complex, what they did. Not just here's a simple checklist that you can all can use, start tomorrow, and all the infections are gone. So keep that in mind when you're thinking about implementing a checklist. Here's a recent study, I think 2014, in Ontario actually, looking at all the surgical checklists that were rolled out. And this study showed failure to reduce any complications, failure to reduce death. So in the light of, we've got some successful studies, we have a recent study showing no improvement in the checklist itself. So this checklist tidal wave that's really happening seems a little bit more like a fad. And maybe it's time to look at more safety design in the departments, some bigger design principles than just rolling out a checklist. These are a couple leading patient safety authorities that have written both the studies that show checklists work and now against using checklists, so to speak. So Peter Provenos is saying we should move away from paper checklists and really design the whole experience of maybe intubation or central line or whatnot around safety, not just the checklist. And again, Lucien Lee, he is in support of a nationwide, nationally funded training program, maintenance of competency, rather than a checklist to improve your outcomes. So a bit of the science behind checklists. Checklists are everywhere. We have grocery lists, we have to-do lists, we use checklists everywhere, and in medicine, differentials, recipes. But the checklist really came from the aviation industry. And I want to talk to you why that is not a good crossover, perhaps. So does anybody know this incident? Yep, good, we'll get back to that. So in the aviation industry, they talk about, they put across this simple narrative when it's really much more complex. And I'll give you a couple examples in the following slides. So they implied that the checklists are what prevented the accident. The checklists are what prevented the error, when really it was a complex design change in the aircraft on top of team training, on top of maybe redesigning something physically in the aircraft. So they'll say things like checklists reduce aircraft accidents, when actually most of the accidents are reduced through physical and procedural design changes that get implemented in the aircraft, then they put the checklist on after. Checklists encourage safer behavior, but actually they may encourage mindlessness, automaticity, discourage perceptual thinking about a task, especially in a stressful situation when you've got to think outside of the box. Checklists are evidence-based. They are only a small portion of the evidence base that's out there in the literature, and often the design is very poor. And it's difficult to separate out checklist versus training. They check that something is correct. No, they just check that something was done. Checklists can be implemented easily, and actually they're quite complex to implement appropriately, at least based on the studies. And looking at, if you look really deep into the aviation industry, it's not easy to implement the checklist that they have. The other thing that's lost in translation in the aviation industry to medicine is that we are dealing with humans. We are working on humans. And whereas when you're flying a plane, you're flying a machine. You're flying a complicated but not necessarily complex machine which you can run checklists on. Simple, long, short, simple checklist algorithm. It's a bit harder in humans to run any checklists with the art of medicine. So a lot of science behind checklists, even down to the exact font you should use to get compliance with your checklist, but not a lot of science really in medicine. There's a lot of favorable implementation conditions, but nothing that links positive effects to checklists. The other issue is, how can we find one checklist to fit all users, all situations? So take intubation, for example. Can we find one checklist that's going to be that everyone can use well and everyone is happy with? Can we find one that when trauma team comes down, we expect them to use? When anesthesia comes down, we expect them to use? When we have a visiting medical student, they can seamlessly use our checklist. It's going to be hard to implement one checklist, even per situation, that fits all. Likewise, many environments aren't really conducive to a checklist, such as if there was a tornado racing towards your house, you wouldn't pull out your checklist to know what to do next.
Samir might.
if you're doing a thoracotomy, I don't think anybody here would pull out a checklist to figure out what to do and then move on to do your thoracotomy. Likewise, on D-Day, there was no checklist on the battlefield for them to know what to do. And of course, if you see a pregnant trauma patient in the emerge coming in arresting, you're not going to run your checklist before you get the baby out. So one checklist per user might be quite difficult, and one checklist per patient situation may be quite difficult to do. What about the obese patient? We use the same checklist for the burn patient, for the gunshot to the face. Are we suddenly pulling out 10 checklists? So construction, design, very important, much more difficult to do than in the aviation industry, and much more complex in the emerge. And back to the Hudson River crash, one of the greatest ditchings in all of aviation history was not done by checklist.
Yes, it was.
Yeah, that's a misconception. So,
I'm going to be talking, I'll use that same picture later.
you can believe who you want. We've got better arguments probably. So they went up, birds hit them, they lost both their engines, there wasn't a checklist for that. The co-pilots started running through all their normal checklists because they didn't know what else to do. And
There's a checklist for double engine failure.
And there wasn't one at the time. The pilot decided, okay.
The pilot who had 50 years experience, wartime experience, all sorts of experience.
So one more thing before I explain this. He was quoted in an article shortly after his ditching, his landing, saying that the most important thing to that landing was his training and experience, which is probably the most important thing besides checklists. Fatigue. Does anybody have evaluation fatigue just for grand rounds alone? Right? Is anybody overloaded with algorithms? Does anybody have guideline saturation? What the? Now, how are we going to add in a checklist for every situation that we need to deal with when we already have algorithms? So be careful, be careful, although variety is recommended. And training, this is kind of the crux of it, training is really the most important thing. Without the proper training, a simple checklist can't really achieve much on its own. Maybe it's there, maybe it helps with training, but it really doesn't do much. The true power of checklists is to establish routine, cognitive offloading, strengthen team performance, enhance shared models, all the stuff that's outside of the typical checklist you would use aviation and other places. It's just very complex in medicine. And to me, that really seems like it's defining training. In infrequently used seen situations, checklists are easily forgotten. You forget how to use the checklist itself. And therefore, you have to train hard on it and often to be able to use it. So again, quality, skill degradation, resilience under pressure is not improved with checklists. Samir might disagree. Should we in good conscience roll out a checklist for Airway without any training program in place? Without any Airway Registry in place? I don't know. Should Airway experts use checklists? They are regarded as weaker interventions, if you look them up. There's lack of support in the research. They are lost in
her story, but she was a healthy 37-year-old female. This blew up a few years ago when it happened. Was going in for a routine nasal procedure. Had her pre-anesthetic visits, which didn't demonstrate any potential complications. So on the day of her surgery, she was rolled into the OR. The anesthetist planned to put her under, sedate her with a bit of propofol, and use a laryngeal mask airway for the rest of the procedure. Well, very quickly the situation turned sour, and the anesthetist was unable to pass an LMA. So her jaw's just a bit tight, gave her some more propofol, put her under more, tried a smaller LMA, that wouldn't fit. 20 minutes went by with this anesthetist trying to play around with LMAs, giving this patient more sedation, trying to get a tube from above while her SATs kept falling and falling and falling. It wasn't until her SATs hit 50% that attempts were actually made to intubate this patient. A staff ENT surgeon came in, an anesthetist from the next room came in. You had 3 consultants, all trained in how to do airways, in the room, while her SATs were 40% for 20 minutes. She did end up surviving the procedure, but unfortunately she passed away 2 weeks later of a anoxic brain injury. Woman on the left, anyone know who that is? Famous Dental? Yeah, absolutely. So, very.
When she didn't have airway issues.
So she was going in for a routine endoscopy. An anesthetist and an ENT surgeon were there with her. She was put under for this procedure. A predictable complication, laryngospasm, unfortunately happened in this case. Same thing. They were unable to intubate, unable to ventilate. She got hypoxic, and she ended up passing away from this as well. How many years of experience did the physicians in both of these rooms have, and had bad outcomes in each? There were decades of expertise, and it didn't end up making a difference. We're all fallible. And skill fade is a real thing. I mean, ask yourself, how many intubations have you done over the last 12 months? And it's a really complex procedure if you think about it. There's probably 40 or 50 steps that are involved in intubating someone and getting the equipment necessary. You're not even always working with the same team. And then you're stuck with the bleeding GI bleed patient. You're going to go through this algorithm in your head because you're the expert and you memorize this for your exams. Are you really going to pull that out and do it well? I don't know. If you talk about transferring skills, I mean, intubating someone in the resus room is one thing, but how about if you take someone outside of the resuscitation room? And I'm not even talking about pre-hospitally, but how about even into a different pod? We've all been asked to intubate someone in pod A before and pod B outside of the resus room. How does that go? All of a sudden you're taken out of your comfortable environment, and I guarantee you steps get missed, equipment gets missed. And the thing is, we get away with it most of the time because our systems are set up with multiple redundancies around us, but it's not a problem until it is, and you have a horrible outcome. You know, hopefully I've talked enough about experts, and this is where Anderson stands in the team. But we see it time and time again. A group of experts does not equal an expert team. And in my view, it's the checklist that's the glue that sticks all of those people together. It gives them a shared mental model of what's coming. And in the face of the unknown, it's really the power of communication that's going to make sure each of your practitioners in that room, nurses, RTs, EDTs, who are all very task-oriented in their own bubbles, come together to perform those tasks as one, as the team, so your patient doesn't suffer. So checklists, what they do is they spread out the knowledge. They take it from outside your brain to everyone else in the room with you who's expected to perform. It empowers all members of the team. Because remember, this is a team that's involved in a resuscitation, not just you. You know, we see examples of checklists in other industries. Dave talked about the surgical safety checklist and the ICU central line checklists. My view on these is very different. The surgical checklist was a very simple intervention where worldwide, from hospitals in poor nations to first world nations, they reduced surgical complication rates by 47% just by introducing a checklist. There was a training period, I grant you, but the only thing they had was checklists. In the initial Provenose study, there was a 40% decrease in central line infection with checklist use. And both of these were routine procedures. So if we translate that, how about the Act Now procedure? And again, this is something else that's come up again and again as I'm running through my ED intubation checklist. People come in and tell me, oh, well, our patients are too sick to use a checklist. We don't have time to use a checklist. We got to intubate this person now. We got to do something now. And if you ask me, that's complete bullshit. This is exactly when you need a checklist. In the high risk, high stakes scenarios, when omitting a step or omitting a piece of equipment will have catastrophic consequences for your patient. That's EDR aside, or the can't intubate, can't ventilate scenario. Imagine if the team members with the Joan Rivers case or Elaine Bromley had talked about their difficult airway plan and what they were going to do in case things failed. I think we could have had a different outcome. I show the same picture because, in my eyes, this was a perfect example of where checklists were just used to perfection. Both of these pilots had tens of thousands of hours of flying time on an A320 and a 737, so experience was not an issue here. Neither one of them had ever been in a crash. The aircrew taken together had over 150 years of flying experience, none of them with any incident. but at the beginning of this flight, the pilots went through their checklists before startup, on takeoff, talking about potential sources of failure. So when failure did happen, they knew who was team leader and what to do next. So in my eyes, there was a checklist and the pilots adhering to this discipline that kept all those people alive. So as I've been walking around the Emerge kind of over the past year with a vial of ketamine in my pocket and a bougie behind my ear and checklist in my pocket, I've heard a lot of skeptics tell me about how checklists are not useful. And if any of you guys have read the Checklist Manifesto, a phenomenal book by the Gwande, who talks about using checklists in different industries. 20% of surgeons still at the end of this period said they didn't think checklists made any difference in their own ORs. But if you ask them another question, how many of you would want a checklist used if it was you who was getting cut for the operation? 97% of them said they would want a checklist used. So I think that's just a really interesting point. So where is our reaction against checklists coming from? I think it's somewhere definitely more visceral. You know, there are caveats to using checklists, especially good ones. You got to be aware of the tick and flip. You need to make sure that you don't have checklist fatigue. If there's, like Dave said, checklists for everything in the Emerge, you're just not going to use them. Good checklists need to be simple and brief, and they need to be well designed by the users, and that's where I'm going to be looking for feedback from everyone in this room. You know, and we show this again. Absence of evidence is not evidence of absence. Checklists are used in every industry that you can think of, from finance to architecture to aviation, to help people perform their job to the best of their abilities as safe as possible. Why are we in medicine not taking some hints for that? I don't want to sit around and wait for the multi-center RCT to tell me that using a cognitive aid in a high-stress situation is going to make what I do safer. So that's all I have for the debate portion. I'll let you guys ponder who you think had the better points there. But Dave talked about the B-17 bomber, and I think this was really where the checklist was born in aviation. Right before World War II, the U.S. military was looking for new aircraft. This was the aircraft they thought they were going to go with from the outset. But on its maiden test flight, this was again a very complicated aircraft, 4 engines. This is one of the first aircraft to have such a configuration. The pilots who were on them had thousands and thousands of hours flying military aircraft. On its maiden test flight in front of the U.S. military, unfortunately they ended up crashing because the pilots forgot to lift one of the gear levers. The U.S. military ended up buying these things anyway, and it ended up saving them in World War II. But the big thing to note here is that when the U.S. military bought these aircraft, they didn't institute a 6-month training program on how to fly this aircraft. That you couldn't get more experience than the people who were already flying it. But what they did do was institute checklists, because this aircraft was so much more complicated than everything that had come before it. And now if I bring that to humans, some of us were probably still alive when bloodletting was a useful procedure, that we were treating kids with cough with heroin. I mean, if you think of the sources of error in medicine and how they've evolved over the last few hundred years, it's really only over the last 50 years where our knowledge of how the body works has just exploded. And now we have 13,000 different diseases we can diagnose, 6,000 or 7,000 different medications, all with their own indications and contraindications. Failures of ignorance are no longer a main source of error. Now it's failures of ineptitude, where we're taking knowledge that we have but failing to apply it correctly in a bad situation, because the volume and complexity of the patients we see is now just too much. So here's the checklist that I've, with the help of Dave and Rem, what we've come up with that we're hoping to roll out here for everyone's use. And again, this checklist, it's a mix of different things. It's a mix of task checks, but most importantly, it's also a mix of communication checks. So bad checklists, like Dave said, they're vague, they're imprecise, they're too long. We want a checklist to enable you and to make you to think, not to turn off your brain and do the opposite. So good checklists, on the other hand, are very precise. They give people the minimum necessary steps required in a certain situation, but leave people with the flexibility to use their expertise in any given situation. And I think really the most important part of the checklist is the last team brief part. So again, this is not a one-size-fits-all solution. We're not asking We're not asking you to intubate every single patient, although I'd love if you intubate every patient with a bougie. I'm not telling you to intubate every single patient with a bougie. What I'm telling you is that this checklist will at least get all the minimum equipment that we expect for an intubation out and ready. And these steps here will allow you to communicate with the rest of the team whom you have never worked with before potentially, to get on the same page, so if you do get into a bad situation, people know what to expect next. So going over this checklist, we debated back and forth on what should we include, what shouldn't we include. This is kind of our first draft version essentially, and we divided it into certain subsections. This is very similar to the checklist that I used working for Sydney Hems. It was mandated that we use checklist before every single intubation. So again, this isn't a tool that we want you to pull out the beginning of your intubation and go through and take 10 minutes checking each of these off. What this is, it's rather called a do confirm checklist. So you go in, and I don't think we'll have time to run through a sim unfortunately, but go in, do what you normally would do to set up an intubation, get your drugs, get your equipment. This is the empowerment of the nurses, RTs, and other people in the room for the moment right before you're about to push paralytic and you're at the point of no return. This is the pause for them to run through out loud to make sure each of these are done. This isn't meant to be a discussion. You've already set all this stuff out. All it is a simple check to make sure things are out and ready. And how many times have you guys been involved in Airways this year where waveform capnography was not set up, still sitting there hanging on the monitor, just waiting for someone to plug it in, but it's not done? Or how many times have you been involved where the BVM isn't hooked up to the oxygen because this patient is stable, or the nasal prongs aren't put on? This is all standard of care for intubations. So what this checklist allows, and it's the same thing when Dr. Gwande rolled this out in operating rooms across the world. Like, you can imagine how what surgeons thought of this. They work in what the rest of the world calls operating theaters, right? This is their showcase to the world about how amazing they are. And now they had someone coming in telling them to use a checklist, right? So it is going to take a bit of time. These are the items we came up with that we think are mandatory. But again, the most important part for me in this is the team brief section and difficult laryngoscopy plan brief. And this is where a few of you may have seen me run through this checklist during my intubations over this past year. It's definitely a change in practice because people aren't used to the airway pause essentially right before you push drugs. But that is my opportunity to talk to my 2 airway assistants and tell them what I expect from them if I don't get this tube on first pass, instead of leaving these people guessing. So I'll be looking for feedback on what you guys think of that. To tie into Dave's piece about training, this is the second part that I'm hoping to roll out sometime over the next, definitely in 2016, but I'm working on it sooner. This is the Airway Registry, and I brought this up briefly during my last Grand Rounds in May. What I want to do is join kind of other tertiary care centers around the world who have started airway registries and develop our own in London, along with the ICU, who are very interested. So essentially what this will be is a quick 60-minute form on every intubation that's done in the emergency department, and it'll just be a treasure trove of data. I mean, one of my big complaints, not the right word, but one of the most difficult parts of returning and being a staff person is all of a sudden I felt that my learning from my fellow peers who have years and years of experience is almost stopped. Every day our emerges put through, 450, 500 patients across the city. You yourself may see 25 or 30 of them. Look at just think about all the lost learning opportunities from all the other patients that your colleagues are seeing, right? What I see this Airway Registry doing for us is 3 to 4 times a year, and I'm happy to lead this with the help of Dave and Ram, is to run a regular airway rounds, 2 or 3 times, or whatever our frequency ends up being, and talk about our airways, talk about what our numbers are. What is our first pass success at LHSC? I don't know. I think other organizations, tertiary care centers around the world are running somewhere around 83%. Are we better than that? I think so, just anecdotally looking around, but we may not be. I have no idea. And the other thing this allows us to do is develop more focused training. Where are the common sources of error? And this was one of the most helpful parts for me in Sydney, where we had airway rounds monthly and talked about every single airway that didn't meet their predefined success criteria. And it was done in a completely non-confrontational, anonymous way. But that was the best learning I did, sitting around in a room full of anesthetists and retrieval docs who've been doing this for 20 years and talking to them about how they would have set up an airway on the side of the road in a way that I may not have thought of. And the same thing applies here. Even though I may disagree with most of what Anderson says, I do want to hear about how he may set up this upper GI bleed, because it may be a little bit different. There is no one right answer, and I think an Airway Registry is a great start. So let's talk about our errors, let's learn from each other, but also let's talk about our successes, because I think on a day-to-day basis we do a pretty awesome job, and we need to spread the word about some of the really good cases that our colleagues are involved in. Okay. This is the second part of the form. So this mimics really closely what's being done in other centers. There's the NEAR registry, there's the Australian Airway Registry, and they're quick forms. Eventually, the hope is to have it electronic, and that's really what the wait is for. That won't happen until sometime in 2016, probably mid to late 2016. But I am hoping to roll out a paper version on Fred over the next probably month or so. And so I will be relying on everyone just to fill these forms out on their own, which obviously isn't perfect, but it's a start, and I promise it'll be quick. So I mean, just to wrap up, if I go back to my case, so as expected, we intubated this guy, and as expected, his blood pressure did drop after intubation. We couldn't feel like I said, we couldn't feel peripheral pulses on him before we started. But with the art line in place, we saw his blood pressure go down into the low 60s. I was thankful I did have the art line in, because in any other situation, we probably would have begun CPR, given a hemorrhaging guy a milligram of epinephrine, and who knows what would happen next. But instead, we had our blood, we had our vasopressors ready, we aimed for hypotensive resuscitation. GI was in the room, ready to scope him as soon as he was intubated, which was excellent. He had a couple varicose bleeds that were banded, and went to the ICU. Unfortunately for him, he had end-stage liver disease, and he was extubated a week later in the unit. But what our team did that night was allow him to live the last 3 to 4 days of his life with his family and say what he needed to say to them and go out with peace and dignity. And to me, that's a win. He may not have walked out of hospital, but that's a win for our resus team, that we gave him the best a send-off as he could possibly get with his family before his next journey. So the ultimate goal here is for me to leave this room every single time with absolutely no regrets about the quality of care that I've provided, and to make sure that what I'm doing in here with my colleagues is the utmost best of what we're capable of. And I think that's what checklists are going to help this group accomplish.
You need a cleanup checklist.
The docs coming in to resuscitate this patient. Ram's going to be our nurse doing a quick handover and helping us out. So essentially, he's going to be playing the charge nurse role in the resus room, and we'll show you how we want him to use the checklist. So.
Can I be a random person in the room?
You can. Yeah, absolutely.
I mean, to just drop family member watching this.
Lights?
Just don't let Davis come in. Keep Davis out of the room.
Nope, left, there you go.
Okay, so.
We're good?
Okay, good.
Trying to.
Hi, docs. Here's your guy's 35-year-old male. He's had a past mental history of asthma. He's been using his Ventolin basically every hour for the last 12 hours. EMS just brought him in. We've been giving him puffers. His respirate's 35. His SATs are 80%. He's just getting worse, guys. So I don't know. We need some help.
Okay. Well, Ram, we're gonna need your help getting some drugs on this guy. Now let's sit him up a little bit so he can breathe better. If you can get some continuous nebs of insulin going, 5 milligrams, we'll get that started. Backwards? All right. Pretend he's sitting up for the purposes of this anyway. So, Ram, I need you to get some Ventolin. I need you to get some Atramet. Yep. We're also going to get some Mag. Dave, this guy's looking like crap. Why don't you just start setting up with some intubation equipment, and hopefully he'll turn around with some of our meds, but if not, we'll proceed.
Put the nebs on here.
Here's some Mag.
Thank you.
So I'm just having some Mag. Perfect. I love IV Ventolin. I'd probably start that too, but that's a discussion for another day.
Mag is being hung or pushing it.
Okay, so his vitals right now are he's decent. He's maintaining a good SAT. He's tachycardic. He's still really tachypnic. He's wheezy on both sides. For the purposes of, let's just say we've kind of done what we had to do for our asthma treatment. Dave, this guy's just really not getting better. I think we gotta proceed and intubate him, all right? So, we'll get our stuff set up. I think he's going to be a potential difficult airway, given the fact he's so short of breath. We have to keep him seated, and then we'll drop him once he's what's his apnea. We'll use ketamine and rock as our drugs. We'll do 100 and 120 each. All right. And then one thing to watch out for after intubation, we'll have to make sure that we do permissive hypercapnia, and we'll have to watch out for hypertension and make sure he's not breath stacking. Okay. All right. Perfect. So let's just make sure we got everything out. So again, this is where you just do practice normally. I'm not. Right now, there's no checklist involved in anything. Go into your resuscitate someone like you normally would. Get your things in.
Here. Covering square. You got your section, your gauge, your section. Put your other here, your correct. Get your back up here. We don't have a glass scope.
Glass scope's down here.
Glass goes on here. Okay. Well, we got a credit kit. I got a drug
Bag that works. Connect oxygen.
All right, he's on
Monitors
2
are on.
nasal prongs. Do we have nasal prongs?
Nasal prongs are underneath there.
Oh, the nasal prongs.
Poorly
Yep.
implemented.
Sweet. Okay, sounds good. He looks like he's in decent position. All right, Dave, so you got the drugs. It's going to be 100 of ketamine and 100
I'm ready to go.
rock. Okay, perfect. All right, Ram?
Okay, so we're gonna do our pause. So set up. We have ear to sternal notch.
Yep, check.
Check. Monitor. It's got EKG, blood pressure, SAT.
Check.
It's got non-rebreather.
Check.
Check. Nasal prongs.
Check.
Suction.
Check.
Okay. Drugs. We have IV access.
Check.
Fluids are connected and running.
Yep, check.
The BP cup is on.
Check. Dave, you use this side.
Do you have the RSI drugs prepared and doses selected?
Yep, we just talked about that. Check.
Okay, let's do our intubation equipment. So we've got a BVM.
Check.
We've got waveform capnography
Check.
available. OPA and an MPA.
Check.
Your laryngoscope tested.
Check.
Okay.
He'd be in the unit by now if I was doing this.
We've got an ET tube.
Check.
With stylet.
Check.
Syringe attached.
Check.
And we got an alternative tube in case it's too
Check.
big or small. We've got a tube tie.
Check.
Okay, team brief. So is there any C-spine
No
mobilization?
C-spines.
Okay, is your assistant briefed on ELM?
All right, so I'm just going to place your hands in case you can't see anything, Dave. Check.
Okay, do you have a plan for difficult laryngoscopy?
So anatomically, this person looks easy, Dave, but if I don't get a good view on with my first look, we're going to proceed to two-hand bag with an OPA, and then we'll use VL as our backup. Check.
You have an LMA
Check.
and a Cripe set available.
Check. All right, check's complete. Anesthetizing at 10:08.
1008.
Go through, finish your intubation. So Ram has never ever practiced that before.
Yeah.
How long did that take?
It was obvious.
50, 60 seconds? Right, and this is with, none of us have actually ever gone through this together. This is just a checklist that we thought was useful for the minimum necessary equipment that we want out for an intubation. This checklist I had down to about 45 seconds with a few weeks of training. And you can see there, like I said in my rounds, it was a mix of equipment checks that we wanted, but it was also a mix of communication checks. So Dave, who I've never intubated with before, knows what I'm going to do if I can't pass a tube. And I think that's really the most important part, to get that shared mental model with everyone in the team. So I think the charge nurse, it's worked most well with the charge nurse using it for me, because they're not directly involved in the actual intubation setup. So it allows them to read it out and for us to quickly, us in the RT or your other airway system, to check each other's work. So that's how we saw it. That's how I see it working. It's going to take some practice. I mean, it's not going to be smooth.
Listen, I think the fear is that a checklist is like tacit approval to suck. And it's not. You have to know what the fuck you're doing. You're going to intubate someone. You should be able to do it without a checklist, right? Like, what if you're in the CT scanner? What if you're in a fucking hallway or something? You got to be able to do it without a checklist. But I think if you're in the right setting, I think it can help. Like, you ever gone grocery shopping?
Like, I know I've gone to the grocery store and fucking left stuff and I have to go take 3 trips. So
I have not been grocery.
well, see, that's my first checklist right there.
Restaurants on your fridge.
Yeah, and they
He's got all the
everything you need.
Anyways, I think
That didn't work, did it?
I think like there is something to be said for saying, listen,
There's
this
something
is not
to
a
be said
club.
for knowing who to call on takeout menu.
Yeah, but like you can't suck. Like you have to know what you're doing. Like before a checklist. A checklist is there just to remind you, hey, did you actually forget that piece of equipment?
Yeah.
Oh, you know what? I left it over here. Maybe I should just put it back where it belongs. Or you know what? I remembered everything, but I forgot that one thing, and that might be critical. So
and
I think
the more you use the checklist, I mean, Ram's saying you need to be able to intubate in environments where you may not have it. And I think getting used to using a checklist in the emerge, in your home, and doing it regularly. If I'm asked to intubate outside of the emerge, I've already gone through this 100 times. I know everything on that list in my head already. So I'm going to argue my chances of succeeding in the CT scanner, intubating someone, are going to be higher because just mentally, I've done that checklist at least 200-300 times over the last year and a half, whether it be sim or real life.
Samir, that part's a bad argument, because I would argue that you need your checklist outside of the environment, even
Agreed.
Right?
Yeah, absolutely.
So I think getting yourself out of that, you actually just contradict yourself by saying, if I've gone through the checklist 100 times, I won't need it then when I'm there.
I still use it every single time. I still use it every single time. I'm talking in Ram's case where you're asked to run over to the CT scanner and intubate someone. I carry my checklist in my pocket. I use it for every intubation, but after having trained with it, most of the time I come up with. But every time I intubated someone on the side of the road or on a cliff in Australia, we forgot something. There was one piece of equipment every time we went through the checklist that one of I or the paramedic forgot. And that's not because we're stupid, but you're thrown into a different environment. You're asked to perform this task, so I do the same thing every single time. I mean, we'll talk about airway setups and stuff later, but for me, that's what the checklist is. So I see it used everywhere.
I'm just going to say, like, in terms of the argument for against, everybody's entitled to opinion, but if you can think of airways that you've had complications with, or you've had to go to second pass or third pass, was there something on the checklist that could have been covered and would have helped you? Like I'm thinking of one case for me, that your discernible notch was definitely the hugest piece of it. And then when I first look and I can't see shit, okay, now I gotta stop and reposition this person because I missed it.
Yep.
You know, I know I missed it, and if I had gone through a checklist, I wouldn't have missed it, and would probably have gone.
Absolutely.
Or
Patient
if I
position
was
is a huge.
super strong, like Scott, maybe I couldn't.
We lay patients flat in the position of death all the time to intubate. It makes absolutely no sense. I mean, optimize positioning before you're going to attempt to pass a tube through. Get them near your sternal notch. Put a couple folded flannel blankets under their head to get them there before you're passing the tube. And this checklist ensures that you're going to do the minimum, what I think are the minimum necessary steps to perform an intubation. So every tube that I've messed up, yes, there was something on here that I could have changed.
Yeah. Samir, one of the things with the Hudson crash, Sullenberger did cut the last checklist short because it was taking too long for the engine out checklist. And he made a decision to land it in the Hudson, cutting the checklist short. And I think that's one of the fears here is that the checklist takes you too long. If something's happening and the patient's crashing, you're going to end up delaying too long. And I think the checklist is a great thing, but you do need to have that mindset that if something is going bad, that you just cut it short and attempt your intubation. You know it's not optimal because you skipped some things in your checklist. So I think that's one of the fears that you might want to overcome as well, is that it's slowing you down.
Yeah, so I mean, the pilots in Flight 1549, they were only 2,500 feet above New York City when they lost both engines. So they pulled out their checklist. They started, item number one on the checklist was fly the airplane. Right? You don't go through all your other checks to try to start the engine. Fly the goddamn aircraft, and then let your co-pilot read everything else out. Did they finish the checklist? No. But my argument there is it's the discipline of teamwork that checklist instilled that allowed them to land that plane in the Hudson and do it safely. We're going to run into situations, and I ran into situations where someone was too sick to run through a whole checklist, and that's when you just stop. And you proceed with your intubation. But at least your patient positioning is going to be okay. I got this disaster airway coming. At least they're going to be an ear to sternal notch when I'm about to put this laryngoscope in their mouth and proceed. So you can abort this checklist at any time if the situation demands it. That's, we're physicians. We're meant to improvise when situations need it. But in a high stakes situation with high risk, this checklist has helped me every single time ensure what I'm doing.